Hi there, my valued, highly treasured and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share with you some very useful tips which may prove handy in your line of duty. So I welcome you to part 87 of our pharmacotherapy MCQ series, which majors in basic oncology. And our first question reads, Mr. PHB, an 83-year-old male multiple myeloma patient, is being initiated on lenalidomide-based regimen at your clinic. As the oncology clinical pharmacist, you are responsible for counseling Mr. PHB. So my question to you is, which of the common toxicities of lenalidomide listed below would you inform Mr. PHB about? Would it be about neuropathy, ototoxicity, sedation, or would it be ototoxicity, neuropathy, and hand-foot syndrome, or would it be coagulopathy, neutropenia, and secondary malignancies, or would it be hand-foot syndrome, coagulopathy, and secondary malignancies? I'll give you 10 seconds to choose the correct answer. So it would be coagulopathy, neutropenia, and secondary malignancies. Now, patients on lenalidomide are at an increased risk for thrombosis and should be started on prophylactic aspirin at doses between 81 and 325 milligrams. Now, neutropenia and secondary malignancies are also potential risks with lenalidomide. Now, although there is a lower risk of peripheral neuropathy with lenalidomide versus thalidomide, some patients may still experience this toxicity. I would like to add that hand-foot syndrome is a common toxicity of many anti-VEGFR tyrosine kinase inhibitors, but not lenalidomide. Then sedation and ototoxicity are typically associated with lenalidomide. Then I would just like to add that exposure to myelotoxic drugs such as the alkylating agents and prolonged exposure to lenalidomide should be limited to avoid compromising stem cell reserve prior to stem cell harvest in transplant eligible multiple myeloma patients. Just for your information. Let's move to the next question, please. And it reads, Mr. TMC, a 35-year-old male patient, received matched unrelated donor hematopoietic stem cell transplantation, after which he has been receiving methotrexate and tacrolimus graft versus host disease prophylaxis. On day +16, he presents to the oncology clinic for review with a rise in serum creatinine from 0.65 to 1.9 milligrams per deciliter. The kidneys are taking a hit. And Mr. TMC's blood tacrolimus levels are found to be 38 nanograms per ml. Now, on examination, the clinical oncologist notices Mr. TMC has developed grade 3 mucositis. So my question to you is, which of the options listed below would be the next best course of action in graft versus host disease prophylaxis in the case of Mr. TMC? Would you opt to continue tacrolimus and reduce the methotrexate dose by 15%? Or would you opt to continue methotrexate and reduce the tacrolimus dose by 10%? Or would you discontinue methotrexate and tacrolimus altogether? Or would you opt to discontinue methotrexate and leave tacrolimus as is? I'll give you 10 seconds to choose the correct answer. Discontinue both methotrexate and tacrolimus. Now, Mr. TMC presented with worsening renal function and a very high tacrolimus level and severe mucositis. Now, worsening renal function could be due to tacrolimus, in my opinion, and mucositis could be due to methotrexate, which is renally cleared. Now, since Mr. TMC has severe mucositis, methotrexate should be discontinued. And in the setting of worsening renal function and existing methotrexate toxicity, reducing the methotrexate dose may not be appropriate. It should be discontinued, in my opinion. And the target tacrolimus reference range, if I remember well, is 5 to 20 nanograms per ml. And it's a TMC presented with very high blood tacrolimus levels and evidence of nephrotoxicity. So lowering the range of tacrolimus to 20 nanograms will further reduce the risk of renal toxicity. Therefore, tacrolimus should be discontinued. Now, just reducing the tacrolimus dose, in my opinion, by 10% will not be appropriate, because the kidney is already taking a hit. So yeah, that would make me settle for C. I would discontinue both immediately. Let's move to the next question, please. And it reads, it is very crucial to recognize fever in oncology patients with neutropenia, since fever could be the only sign of infection in this cohort of patients. So my question to you is, which of the statements listed below best defines febrile neutropenia in this cohort of patients? Is it temperatures exceeding 100 degrees Fahrenheit and an absolute neutrophil count below 1,500 cells per mm cubed? Or would it be temperatures exceeding 101 degrees Fahrenheit and an ANC below 500 cells per millimeter cubed? Or would it be temperatures exceeding the 101 degree Fahrenheit mark and an ANC below the 1,500 cells per mm cubed? Or would it be a temperature above the 100 degrees Fahrenheit and an ANC below 500 cells? I'll give you 10 seconds to choose the correct answer. B is the correct answer. Now, according to the IDSA guidelines, any patient with a single oral temperature equal to or above 101 degrees Fahrenheit or a temperature of equal to or above 100 degrees 0.04 Fahrenheit lasting 1 hour or longer is considered to have fever. Neutropenia is defined as an ANC below 500 cells per millimeter cubed, or an ANC that is predicted to reduce to below 500 cells per mm cubed in the next 48 hours. So that makes answers A, C, and D wrong. It is important to note that these definitions of febrile neutropenia are no hard and fast rules. Clinical judgment should be used to identify which patients require antibiotic treatment, even if they don't meet these specific definitions. I would just like to emphasize that profound neutropenia refers to an absolute neutrophil count below 100 cells per millimeter cubed. And functional neutropenia describes patients whose hematologic malignancies result in impaired phagocytosis and killing off pathogens, which puts them at an increased risk for infection despite a normal neutrophil count. And these include patients with acute leukemias. They can fall in that category. Let's move to the next question, please. And it reads, Mrs. PWN, a 66-year-old female patient with confirmed clear cell renal cell carcinoma, RCC, underwent a radical nephrectomy 3 years ago at your hospital. Recently, your medical oncologist gave her a diagnosis of hepatic and lung metastasis. Things are not looking good. Her Karnofsky's performance status is currently 70%, and her HB is 7.3. The LDH is 3 times the upper limit of normal. The ALT and the AST is 1.5 times the upper limit of normal. So my question to you is, which of the treatment options listed below would best suit Mrs. PWN now? Would you settle for Sorafenib? Would you settle for Ipilimumab, co-administered with Nivolumab? Or would you settle for Axitinib? Or would you settle for high-dose interleukin-2, IL-2 therapy? I'll give you 10 seconds to choose the correct answer. Settle for Ipilimumab and Nivolumab. Now, based on the MSKCC prognostic model, Mrs. PWN, in my opinion, is considered poor risk or poor performer. She has a poor performance status, and she also has low hemoglobin levels and an elevated LDH. Now, according to the NCCN guidelines, Ipilimumab, co-administered with Nivolumab, is considered a preferred regimen as first-line therapy in poor or intermediate risk patients with metastatic renal cell carcinoma. It has been shown to increase overall survival and overall response rate compared to sunitinib, for example, in this kind of cohort of patients. Now, Axitinib has been evaluated in second-line therapy for patients previously treated with cytokine therapy or sunitinib, and is considered a category 2B recommendation for first-line therapy in the NCCN guidelines. Now, high-dose IL-2 isn't considered a preferred regimen and should be reserved for patients with excellent performance status and normal organ function. So that makes D wrong. Then Sorafenib, answer A, hasn't been evaluated for first-line treatment of patients with the metastatic RCC, and I would just like to add that phase 2 trials comparing Sorafenib with IFN failed to show any additional benefit with Sorafenib. Now, Ipilimumab, co-administered with Nivolumab, is preferred as a regimen for patients with relapsed or with relapsed medically unresectable stage 4 clear cell renal carcinoma who are considered poor or intermediate risk, and the NCCN guidelines no longer recommend Sorafenib as first line for relapsed or medically unresectable stage 4 predominantly clear renal cell carcinoma. So remember that. It is still prevalent internationally due to its relative affordability, unfavorable clinical efficacy, and safety for specific patient populations, such as those in the Asian population. Just as a by the way, those many was justify why the use of ipilimumab and nivolumab would be the best bet in this particular question. Let's move to the next question, please. And it reads, Mr. JPP, a 65-year-old male patient who was recently diagnosed with Burkitt's lymphoma, presents to the oncology clinic for evaluation prior to the initiation of therapy. Some of his pertinent labs include sodium of 148, potassium of 4.5, serum creatinine of 1.8, blood glucose of 130, LDH of 1500. So my question to you is, which of the factors listed below are risk factors for tumor lysis syndrome? Is it existing renal insufficiency, high sodium Burkitt's lymphoma, or is it high sodium, high lactate dehydrogenase Burkitt's lymphoma, or is it Burkitt's lymphoma, high lactate dehydrogenase and existing renal insufficiency, or is it high lactate dehydrogenase, high blood glucose and existing renal insufficiency? I'll give you 10 seconds to choose the correct answer. So C is the correct answer. Now, cancers with a high proliferative rate and tumor burden put patients at a risk of tumor lysis syndrome. In addition, cancers sensitive to chemotherapy treatment will undergo rapid tumor lysis, which further increases the risk of TLS. Now, just like to add that Burkitt's lymphoma has a high proliferative rate and is responsive to chemotherapy. Now, elevated LDH is an indirect indicator of high tumor burden. Now, patients with impaired renal function are at an increased risk for TLS and its complications due to inability to handle excess concentrations of uric acid, phosphate, and even potassium. Now, high sodium and blood glucose levels don't increase the risk of tumor lysis syndrome at all. So that makes any option with those two wrong. I'd just like to add that rapid tumor lysis leads to increased levels of phosphate, potassium, uric acid, and cytokines, which leads to the development of tumor lysis syndrome. And I would like to add that allopurinol inhibits xanthine oxidase, which prevents the uric acid production, but it doesn't remove existing uric acid, whereas rasburicase removes uric acid by enzymatically degrading it into what we call allantoin, ALLANTOIN, which is excreted via urination. Let's move to the next question, please. And it reads, Mrs. APN, a 35-year-old female patient, presents to your hospital for regular checkup. At the age of 74, her father was diagnosed with colorectal cancer. He succumbed after numerous lines of treatment. APN seeks to know at what age to initiate colorectal cancer screening via colonoscopy for herself. And she also seeks to know what risk she is and how often she should repeat the screening in case it turns out negative as per this NCCN guidelines. So my question to you, is it age 63 years? Is she high risk and should she repeat it every 5 years? Is it age 40, high risk and every 5 years? Is it age 40, high risk and every 10 years? Or is it age 50, average risk and every 10 years? I'll give you 10 seconds to choose the correct answer. So B is the correct answer. Now the NCCN colorectal cancer screening guidelines recommend those with a positive family history of colorectal cancer, that is one or more first-degree relatives, to initiate colonoscopy screening at the age of 40 years or 10 years before the earliest diagnosis of colorectal cancer, and to repeat it every 5 years and not every 10 years. Now, this particular patient, APN, is considered high risk due to the fact that her dad, who happens to be a first-degree relative, had a history of colorectal cancer. Now, first-degree relatives with confirmed adenomas, that is high-grade dysplasia which is equal to or above 1 centimeter in size, or those with villus or tubovilus histology, or even advanced senile serrated polyps, which are abbreviated as SSPs, which are above 1 centimeter in size, or any dysplasia, would make a patient fall in the category of high risk. Now, the colonoscopy screening interval differs for family history of colorectal cancer versus, say, the adenomas or the SSPS. So that is to say every 5 years versus every 5 to 10 years respectively, if the first screening is negative. Now, criteria for colorectal cancer screening can differ depending on guidelines reference, but in this particular case, we are focusing on the NCCN guidelines, which clearly outline their recommendations for high-risk individuals based on family history and colorectal cancer versus adenomas or the SSSPs. Now, colorectal cancer screening in average risk individuals can reduce colorectal cancer mortality by detecting the cancer at an early and curable stage, and it may decrease colorectal cancer incidence by detecting and removing polyps. Just as a by the way, let's move to the next question, please. And it reads, Mrs. JTT, a female patient with metastatic colorectal cancer, is initiated on Panitumumab, and then 2 weeks later she presents to your medical oncologist with a rash located on her face and upper trunk. The oncologist feels strongly it is a case of folliculitis with pustules present. So my question to you is, what strategy would the oncology team have used at the start of therapy to minimize or to prevent this acneiform rash? Would they have opted to use strategy A, where before Panitumumab is started, the patient should begin Pimecrolimus cream applied to the face and to the trunk with moisturizers, or should such patients apply moisturizers with a sunblock to the exposed areas if they are going outdoors, and co-administer or apply topical steroids and doxycycline? Or is it true that before Panitumumab is started, Tazoroten 0.05% cream should be applied to the face and to the trunk with sunscreens? Or is it true that at the first sign of the rash, patient needs to begin to apply topical benzoyl peroxide until the rash disappears? I'll give you 10 seconds to choose the correct answer. So before Panitumumab is initiated, such a patient should be applying moisturizers, sunblock to exposed areas if going outdoors, and topical steroids alongside doxycycline. Now, a study evaluating the use of preemptive therapies versus starting at rash onset showed a 50% reduction in significant rash with the preemptive approach. And in this particular study, hydrocortisone 1% was used with moisturizers, with sunscreen, and either doxycycline or minocycline. And yeah, we should prevent the skin from drying out and protect it from the sun in such patients. And we should not use acne medication, since this is not acne. And then the use of antibiotics prophylactically at the onset of pustule formation is critical. Now, topical tazarotene or Pimecrolimus aren't recommended at all in this cohort of patients. So all those many ones justify why B is the correct answer. Let's move to the next question, please. Reads, Mr. ALK, a 57-year-old male patient with confirmed small cell lung cancer, is receiving cisplatin at a dose of 75 milligrams per meter squared on day 1, alongside etoposide at a dose of 100 milligrams per meter squared on days 1, 2, and 3. The oncology team administers palonosetron, aprepitant, and dexamethasone as his antiemetic regimen. He returns to the oncology clinic the following day with complaints of nausea and vomiting. So my question to you is, which of the medications listed below would you recommend for Mr. ALK's treatment of breakthrough nausea and vomiting? Would it be 25 milligrams of promethazine orally? Would it be 8 milligrams of ondansetron IV? Would it be 1 liter of normal saline and haloperidol 2 milligrams IV? Or would you settle for a liter of normal saline alongside 8 milligrams of ondansetron administered IV? I'll give you 10 seconds to choose the correct answer. To infuse a liter of normal saline and administer 2 milligrams of haloperidol IV. Now, administration of IV fluids is an effective strategy in the management of chemotherapy-induced nausea and vomiting. Remember, the treatment of breakthrough emesis requires the use of an agent not found in the patient's prophylactic regimen, and therefore the use of ondansetron, which is a 5-HT3 receptor antagonist, isn't recommended since the patient has already received palonosetron before chemotherapy. It belongs to the same class, so that would be therapeutic duplication. Now, haloperidol or phenothiazines such as chlorperazine or promethazine are options for treatment of breakthrough nausea and vomiting, and the use of the oral route, that is oral promethazine, at a dose of 25 milligrams for the treatment of breakthrough nausea and vomiting is not the preferred route. Since the patient is already throwing up, it would be difficult to retain the tablets. So that disqualifies all those other options. Let's move to the next question, please. And the next question reads, Mrs. GBP, a 62-year-old female patient, presents to your hospital with postmenopausal bleeding which has lasted 90 days, 3 months. Shortly afterwards, she undergoes surgical staging with a TAH/BSO with lymph node dissection and is found to have endometrioid adenocarcinoma with less than 50% invasion of the myometrium. No lymph node involvement is present, and she is given a diagnosis of stage 1A, grade 1 disease. So my question to you is, which of the treatment options listed below would be the most appropriate for Mrs. GBP now? Would it be adjuvant vaginal brachytherapy? Would it be observation? Would it be adjuvant doxorubicin and cisplatin, or would it be adjuvant carboplatin and paclitaxel? I'll give you 10 seconds to choose the correct answer. Would opt to observe this patient. Now for stage 1A, with less than 50% myometrial invasion and grade 1 tumors, the standard treatment is TAH stroke BSO, which has been done to this lady, followed by observation. Now alternatively, continuous progestin based therapy, that is for example megestrol acetate or medroxyprogesterone, or even levonorgestrel containing intrauterine devices, may be considered in these patients with non-invasive disease who wish to undergo a fertility sparing approach to treatment. Now adjuvant vaginal brachytherapy and or external beam pelvic radiation, what we abbreviate as EBRT, can be considered in higher stage, that is high grade, such as 2 or even 3, or in poor histology disease, not in this particular case. Now adjuvant chemotherapy isn't recommended for low risk early stage disease like this particular one, and that rules out D and C. Now according to a large prospective study, the Gynecologic Oncology Group, which is abbreviated as GOG, reported that the 5-year survival for patients with stage 1 endometrial cancer was over 90%, and as such, the goal of treatment is to cure the patient. For my highly esteemed viewers and listeners, that brings us to the end of this video. If this video benefited you in any way, I would like to remind you to give it a thumbs up, to like it, and to share it widely, and leave a comment at the end of it. And if you haven't yet done so, I humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the very, very best is yet to come, and I'm very thankful that you viewed and listened to this video. I sincerely appreciate your partnership, your continued support, and your very kind collaboration, and I look forward to interacting with you in the next video. Thank you very much.